Welcome back to another high-yield PMHNP review session with Clarity Education Systems. I'm Dr. John Rossi, and I'm here to help you build confidence, sharpen your knowledge, and get one step closer to passing your certification exam. If you've been with us before, you know how we do things, engaging evidence-based questions with in-depth rationales to make you understand the material that you're going to be tested on, not just to memorize it, but something that you will be able to utilize for the rest of your career. If this is your first time joining us, get ready. This is a free excerpt from our weekly live sessions held every Wednesday night at 7 p.m. Mountain Standard Time. So these sessions are exclusive to Clarity Education students and include real-time discussions, strategy breakdowns, and an open question and answer forum to help you tackle any challenges you've been facing. Today, we're diving into more must-know content. So grab your notes, clear that mind, and let's go ahead and get started. So let's start this session with an important skill every PMHNP needs, applying motivational interviewing effectively. This case focuses on the planning stage of MI, where we help patients strengthen their commitment to change. So the question reads, a 38-year-old female with a history of alcohol use disorder presents to your clinic after several MI sessions. She now expresses readiness to reduce her drinking, stating, I'm ready to cut back. I think I can do this. As a PMHNP, you apply MI's planning process to support her commitment. Which of the following best demonstrates the planning process in your response? Option A, ask. What steps do you think you can take to cut back? Reflect her plan and affirm her readiness. B, ask. How many drinks will you reduce and provide a structured reduction plan? Option C, what has helped you in the past and suggest an AA meeting scheduled? And D, ask, are you sure you're ready? And provide a list of local treatment programs. So take a moment to think about it. What response best supports her autonomy and commitment to change? Okay, if you chose A, spot on. Let's go ahead and break it down. So the planning stage of MI is all about helping the patient solidify their own commitment and develop a plan based on their own insights. Instead of prescribing a course of action, we guide the patient in exploring how the how of change works. By asking, what steps do you think you can take to cut back, we evoke, and that's a key word in MI, evoke her strategies. Reflect, again, another key word, her thinking on reinforcing her plan, and then we affirm, another key word, her confidence, all of which align with MI's client-centered approach. So studies have shown that patients are more likely to follow through on a plan that they create rather than one imposed by you, the clinician. Okay, so let's quickly go over the other options and why they don't align to the MI's planning process. So option B, asking about drink numbers and providing a structured reduction plan. So remember, this imposes structure instead of evoking the patient's own solutions. So while setting goals is important, this step should come from the patient, not dictated by you. Option C, asking about past strategies and suggesting AA. So reflecting on the past success can be useful, but immediately shifting to an AA recommendation places the focus on our agenda rather than hers. MI requires this collaboration between you and the patient, not prescriptive direction. And then option D, questioning readiness and listing treatment programs. So asking, are you sure you're ready? This induces doubt and undermines her confidence. Additionally, providing this treatment option without her input doesn't align with the MI's emphasis on autonomy and patient-led planning. All right, so the key takeaway here is MI planning equals evoke, reflect, and affirm. So motivational interviewing is one of the most effective tools in substance use treatment, but only when we follow its core principles: evoking change talk, supporting autonomy, and reinforcing confidence. So this patient has already taken a big step by saying, I think I can do this. We've entered into a new planning stage. We've gone past pre-contemplation. We're transitioning from contemplation to planning, utilizing that trans-theoretical model of change. So you're going to help her take the next step. on her terms. All right, let's keep the momentum going. Let's go on to the next question. So let's build on this idea of motivational interviewing skills. And this time we're going to focus on the evoking process. This is where we help patients connect their own reasons for change. The question reads: a 42-year-old male with a history of smoking and chronic obstructive pulmonary disease, or COPD, presents to your clinic with high ambivalence about quitting. He states, "I know I should quit for my health, but smoking is my only stress relief." As a PMHNP, you apply MI's evoking process to explore his motivations. Which of the following best demonstrates the evoking process in your response? Okay, so at this point, I would have you utilize our test taking strategies that you'll learn in the seminars. Biggest thing I want to point out is we are definitely in the contemplation stage. This person knows that they need to quit smoking, but they're not ready to make that commitment yet. So our options are: A, reflect. You see the health benefits, but rely on smoking for stress and ask, what might life be like if you quit? Option B, reflect. You're torn about quitting and ask, what steps have you taken to quit in the past? Option C, reflect. You value smoking for stress relief and ask, do you know the risks of COPD progression? And then option D, you're aware of the health issues and ask, are you ready to quit and set a quit date today? All right, think about MI's evoking stage. It's all about drawing out their reasons for change, which is going to be the most key help here in this process. So, which one of these explores their own motivations? All right, if you chose A, awesome. That's the correct answer. So, let's go ahead and break that down. So, by reflecting both sides of his ambivalence, acknowledging that he sees the benefits but also values smoking for stress relief, we validate his struggle without punishing him and without pushing him. Then, by asking, what might life be like for you if you quit? We evoke change talk. So, this type of open ended exploratory question encourages him to articulate his vision of a smoke free life, making change feel more personal and possible. So there have been plenty of studies, one in a behavioral medicine journal recently, that confirms evoking internal motivation leads to stronger commitment and lasting behavior change compared to just simply providing facts or advice. All right, so again, let's go over those other answers and why they don't quite fit. So option B, asking about past steps. Again, this keeps the focus on the history, not the current motivation. So past experiences matter. Evoking is about future-oriented talk. Option C, asking about risks. So this shifts into an educational exchange, which can feel like, persuasion. So while discussing health risks is important, evoking keeps the patient's motivation at the center of it, not clinician-driven facts. And then option D, asking about a quit date. This jumps ahead into the next stage, right? We're in contemplation, and that jumps right into planning before the patient has expressed readiness for action. Evoking comes first. Patients need to connect with their own reasons for committing to the plan. All right, you've heard me say a lot about the trans-theoretical model of change. Again, MI plays right into that, so make sure that you're studying that in the seminars. All right, so this case, overall, our key takeaway, MI evoking equals acknowledge ambivalence, ask open-ended questions, and elicit change talk. So the case, it highlights the power of guiding, not directing. Patients often already know the risks and benefits. We just need to help them voice why change matters to them. So when you master the evoking process, you're not just treating a condition, you're empowering your patients to make meaningful changes on their own. All right, moving on to question number 3. Let's keep building again on that motivational interviewing. A lot of students in the course have been asking about MI. And so this case, it focuses on MI's core elements: partnership, evocation, acceptance, and compassion. So these principles are going to help create a safe and supportive space for behavior change within a therapeutic environment. The question reads, a 34-year-old female with a history of social anxiety disorder presents to your clinic with low desire to engage in social activities. She states, I know I should go out more, but I don't really want to. It's too stressful. As a PMHNP, you apply MI's core elements of partnership, evocation, acceptance, and compassion. Which of the following best demonstrates these elements in your approach? Option A, highlight the benefits of socializing, encourage her to attend a group event, and schedule a follow up. Option B, express empathy, evoke her values by asking what she hopes to gain from socializing, and affirm autonomy. C, confront her avoidance by explaining how isolation worsens anxiety and recommend exposure therapy. Or D, provide a list of social activities and direct her to choose one to try by the next time they visit. So think about MI's spirit here: collaboration, drawing out the patient's own motivations, and then respecting their autonomy. Which one of those embodies these principles? Awesome. If you chose B, absolutely correct. Let's go ahead and break it down. So, MI's core elements ensure that we meet the patient where they are rather than pushing our own agenda, right? We've talked about that. So, by expressing empathy, we validate her feelings and reduce resistance. Evoking her values by asking what she hopes to gain from socializing helps her identify potential benefits rather than being told what to do. Affirming her autonomy respects her choice, reinforcing what she is in control of on her decisions. So the patient already knows she should socialize more. Our role in MI is not to lecture, but to help her explore what socializing really means for her. So recent research shows that MI driven interventions increase intrinsic motivation and long term engagement in anxiety management strategies. Okay, moving on to the others here. Let's clarify where they were wrong. So option A, highlighting benefits and encouraging participation. This is a directive, focusing on what we think is best rather than drawing out her emotions. While socializing has benefits, true motivation comes from her own values. Option C, confronting avoidance and recommending therapy. So this approach is judgmental and directive, violating MI's acceptance principle. So while exposure therapy is useful, MI focuses on exploring readiness rather than pushing interventions before the patient is engaged. And then finally, D, providing a list and directing her to choose. This imposes, again, our agenda. Even though structured options can be helpful in later stages, MI requires a collaborative approach, not a directive one. So our key takeaway here: MI core elements equals partnership, evocation, acceptance, and compassion. So when we apply MI effectively, we create a space for change. That's the real goal here, not pressure for compliance. So the more the patient feels heard, the more they own their own decisions, leading to lasting behavior change. All right, fantastic. Let's go ahead and move on to the next question. And it reads, now, we're going to say a PMHNP is studying the relationship between sleep duration and depression severity in 40 patients with major depressive disorder. So we're switching gears here now, and we're going to start looking at research interpretation. All right, so using Pearson's correlation, the analysis yields a correlation coefficient of 0.65 with a p-value of 0.01. Which of the following best interprets this result? Option A, conclude that sleep duration has no impact on depression severity due to the positive correlation. B, determine that longer sleep duration is significantly associated with higher depression severity. C, suggest the correlation is not significant due to the p-value being less than 0.05. And D, recommend increasing sleep duration to reduce depression based on the correlation. All right, so think carefully here. This is about correctly interpreting correlation results. What does correlation coefficient of 0.65 and a p-value of 0.01 really tell us? All right, so the correct answer is here, B, determine that longer sleep duration is significantly associated with higher depression severity. So let's break it down. So Pearson's correlation coefficient, this is R equals 0.65, tells us two things. So the strength of the relationship between the two variables, moderate to strong correlation. and the direction of the relationship. This is a positive means both variables increase together. So the p-value of zero point zero 0.01 means the result is statistically significant. So it's unlikely due to chance. Therefore, we can conclude that as sleep duration increases, depression severity also tends to increase. However, correlation does not imply causation, meaning we cannot say increased sleep causes higher depression severity, just that they are related. So let's go over the other incorrect answers. So option A, concluding no impact, this misinterprets the correlation. A positive R means there is a relationship, not just causation. Saying no impact ignores the significant association between the two. Option C, suggesting the correlation is not significant. So remember, a p-value of 0.01, anything 0.05 and below, actually is going to confirm significance. A result is considered statistically significant, again, when you have a p-value of less than 0.05. So obviously this statement is the opposite. It's wrong. And then option D, recommending increased sleep. So correlation does not mean causation, right? While longer sleep is associated with higher depression severity in this study, we don't know if more sleep causes increased depression, or if another factor like medication side effects, atypical depression, or poor sleep quality is influencing both of the variables. Okay, so our key takeaway here is Pearson's correlation equals strength and direction, not causation. Mastering statistical interpretation helps you critically evaluate research and apply findings appropriately in a clinical practice setting. So always ask, does this study show association or true cause and effect? All right, awesome job. Let's move on to our last question of this free session. Let's dive into research design now. This is an essential skill for evidence-based practice. So in this question, we focus on internal validity. So let's move on to our question, and it reads, a PMHNP is conducting a study to evaluate the effectiveness of a new cognitive behavioral therapy, or CBT, protocol for reducing PTSD symptoms in veterans. The study shows significant symptom improvement, but participants also received concurrent stress management workshops. As a PMHNP, which of the following best addresses a potential threat to the internal validity of this study? Option A, randomize participants to CBT or a control group without workshops to isolate CBT's effect. Option B, increase the sample size to determine and ensure generalizability across the veteran populations. C, use a self-report scale with higher sensitivity to detect subtle symptom changes. Option D, conduct follow-up interviews to confirm participants' adherence to the CBT protocol. Okay, take a moment to think about what threatens the study's internal validity. How do we determine whether CBT and not the workshops caused the symptom improvement? All right, if you picked A, you got it right. Randomize the participants to CBT or a control group. So internal validity, this is all about ensuring that the observed effects in the study are actually caused by the intervention. In this case, that's going to be CBT. So the biggest issue here is confounding variables, right? Participants attend both CBT and stress management workshops. This means we can't be sure if symptom improvement came from CBT, the workshops, or a combination of both. So the best way to address this problem in research is by randomization. So by randomly assigning participants to either CBT alone or a control group without workshops, that's where we can confidently say whether CBT alone is effective. This helps eliminate that bias and then strengthen the study's internal validity. All right, let's go over the incorrect choices here and why they don't really explain or address internal validity. Option B, increasing sample size. So more participants improve external validity, how well the results generalize to other populations, but they don't fix the confounding variable problem. Option C, using a more sensitive self-report scale. Improvement in these assessment and measurement tools, this is going to help detect any changes in symptoms, but it doesn't really separate the effects of CBT from workshops. So the issue here isn't measurement, it's isolating cause and effect. And then finally, option D, conducting follow-up interviews. So checking adherence is going to ensure participants follow the CBT protocol correctly, which helps treatment fidelity. However, it does not eliminate the confound introduced by the workshops. So our key takeaway is internal validity is going to equal controlling confounding variables. This is why strong research design matters. Without proper controls, we really might think an intervention works when in reality it doesn't. Other factors are influencing the outcome. As PMHNPs, understanding study validity helps us critically evaluate evidence and then applying the best interventions into practice. All right, excellent job on that. So this brings us to the end of today's session. Awesome job. And at this point in our live sessions, every Wednesday night, we open the floor up for an interactive Q&A. And this is your time to ask any questions that you may have in order for us to support your needs. So we can talk about your semester, any changes or insights from your coursework, the Clarity Review Program, any clarifications, strategies, or study techniques, concepts from your studies, so anything you came across that needs further explanation, practice questions, so why an answer was right or wrong, and how to think through them, and then finally, anything else that's on your mind. This is an open forum here to make sure that you feel confident and supported every step of the way. All right, so remember, this is a tough journey. So to close out, I just want to share a few comments here. If you're a current student in the Clarity education system, you can join us live through the PMHNP student portal. Just click the live session link and then you'll be put right in. So remember that this journey is tough, but you're not alone. We're here to guide you, answer your questions, and help you stay on track for success. So our first thought here is a powerful reminder. The best way to predict the future is to create it. And this comes from Abraham Lincoln. So your future as a PMHNP isn't just something that happens to you. It's something you build with every choice, every hour of study, and every challenge you push through. And now onto one of my favorites from Aristotle. We are what we repeatedly do. Excellence, then, is not an act, but a habit. So your success is not about one big effort. It's about showing up day after day, doing the work and studying and staying committed. Every time you choose to study, review, and challenge yourself, you're building excellence. So keep going, stay focused, and trust yourself. I'll see you next Wednesday at 7 p.m. Mountain Standard Time. So keep striving, keep growing, and remember, you are capable of greatness. Bye-bye.